Hello and namaste again in third BNB knee course pre-course online discussion. I am Dr. Vivek Basukala and for today my moderators are Professor Dr. Amit Joshi from C. Birendra Hospital and Dr. Sailendra Dual Shrestha from Armed Police Force Hospital. Today my topic of discussion is approach to knee dislocation, a different perspective. I would like to start my presentation with this video clip. This is a video clip from 2017 when the Chicago Bears were competing with New Orleans and Jack Miller, the player from Chicago Bears, injured his left knee joint because of hyperextension injury, following which he had popliteal artery injury and knee dislocation, for which emergency surgery was done, and this his career threatening injury. This picture shows the wall of uncemented bricks, which is pretty unstable compared to this wall, which is cemented. So, similarly, in knee joint, because of its bony architecture per se, it is very unstable joint, and which becomes stabilized once there is addition of ligaments, just like the bricks are attached with the cements. So this is relive of our residency days. In our early days, we'll be very happy when we get the case of knee dislocations from ER, and this is the condition of final year student or the consultant who knows what actually is the knee dislocation. So knee dislocations are defined as clinical or radiological loss of tibiofemoral congruity. It accounts for 0.02% of all orthopedic injuries and 0.5% of all joint dislocation. Once we have the case of knee dislocations, we must rule out the serious complications which may be life or limb threatening, like vascular injuries and neurological injuries. These epidemiological data may be underestimated, as this does not include the functional dislocations, that is spontaneously reduced knee dislocations, which makes the pretty much amount of knee dislocations. So vascular and neurological injuries most commonly occurs in the popliteal artery and common peroneal nerve because of its peculiar anatomy. The popliteal artery is located in between the two static structures, the adductor hiatus and soleus leis. Once we get the case of knee dislocation, we should be very careful to see the foot of the patient. We should rule out the foot drop and we should rule out the ischemic limb. So make sure feet are okay before evaluating the knees. Knee dislocations also can occur with high energy, low energy, or ultra low energy injuries. High energy means the road traffic accidents, low energy includes the sports injuries, and ultra low energy means simple fall in obese individuals. So we must not forget the concept of functional dislocation, that is the cases where there is spontaneous relocation of the so when there is isolated PCL or PLC injuries, we should always think about the functional dislocation and see for the other injuries. Once we get the case of knee dislocation, X-ray should be done, and according to X-ray, the Kennedy anatomical classification should be done. It gives some reduction hint, and reduction should be preferentially done in the OR, and under anesthesia, the evaluation should be done. The tests that should be done are Lachman test and anterior draw test for anterior cruciate ligament, posterior sag and posterior draw test for posterior cruciate ligament, valgus and varus stress test, and dial test for medial and lateral structures. After completing this examination, now we will be able to do the anatomical classification of Schenck, which was devised in 1992 by Schenck, and it depends upon the number of ligaments injured during the knee dislocation, and it also includes the fracture dislocation, arterial injury, and nerve injuries. This is famous picture from the original article of Schenck, where he compared knee with the chair with its four legs, and at least two of its legs must be injured for a knee to be dislocated. There has been many attempts to classification, and till date the Schenck anatomical classification is considered to be a perfect one. But still the Schenck classification also misses the articular cartilage injuries, which may account to up to 28.3%, and bone contusion and microfractures, meniscal pathology, and extensor mechanism injuries. Once knee dislocation is reduced, second step is retention of reduction. So for retention, there are old ancient techniques like plaster and splints, the very inhumane technique, the transarticular Stillman pins, the knee spanning external fixators. But the new recent trend is towards the anatomical ligaments reconstruction. Previously, only focus were on bones, and we used to be happy once we reduced the knee joint. But knee dislocations means ligaments disruption, and ligament good looking x-rays may not be uh, always give the good result in the future, because knee ligaments are not seen in the x-rays. So we can conclude the knee dislocation are ligamentous disruption with loss of continuity of tibiofemoral articulation. We most of us agree on immediate need of reduction and immediate need of retention of reduction. But what after that is a controversial matter. The still debated topics are whether these cases should be managed operative or non-operative, whether if planned to manage operatively, whether they should be managed early, that is less than 3 weeks, or more than 3 weeks, the late surgery, whether repair should be done or reconstruction should be done for the ruptured ligaments, and whether early simultaneous repair to be done or stage repair or reconstruction should be done. There has been debates about the choice of grafts, and there has been much debate about the sequence of graft tensioning and fixation. So there has been lots of debates and lots of controversies in these topics, and after extensive sorts of literature, there have we found some answers, like operative treatment is always better, and we should always offer operative treatment to the patients unless the patient is very old, um, very with multiple comorbidities, or patient is immobile. And surgery within 3 weeks, that is early surgery, always gives good results. If possible, repair should be done for medial side, but for lateral side and for cruciates, reconstruction should be done. And if we are suspicious about the repair quality of repair, we should never hesitate to augment. And single stage reconstruction followed by good physio has better results, and autographs are only options in our country, and PCL followed by ACL, then PLC, and MCL POL is sequence of tightening in setting of one stage surgery. So challenges of multi-ligament surgeries are the scarcity of graft, the tunnel convergence, the time constraint. So till now we have discussed about the knee dislocation, which can be reduced uh, under anesthesia or without anesthesia by close means. But there are some knee dislocations which cannot be reduced by close means, and this is the pathognomonic external sign of irreducible knee dislocation called Pucker sign, of which we discussed in last class. This Pucker sign is because of incarceration of medial structures of knee joint into the joint space. Then this is the MRI picture in which we can see the incarceration of medial structures into the knee joint, thus leading to irreducible knee dislocation. This is clinical picture of knee dislocation which is reduced in OR under anesthesia, and this is the clinical test, the anterior alignment, posterior alignment, anterior drawer test and posterior drawer test, the valgus and varus stress test, which shows the anteroposterior laxity and mediolateral laxity. So we provisionally classified this case of KD4 knee dislocation, and we did single stage multiple ligament reconstruction, and this is 2 months follow up of the same case with good results. So conclusions: knee dislocation is actually a multi-ligament injury. Functional dislocation are pretty common. We should be very careful to rule out them when we see isolated PCL or PLC injuries. And early anatomical ligaments reconstruction followed by rehab is state-of-art treatment at present. So this might be the time to change our perception on knee dislocation. Knee dislocation is not the bony injury, it is ligamentous injury. So let's save knees, and thank you.